Hi, everybody, and welcome to today's episode of the EmPower Hour produced by the EmPower Plant by Basic Brooks. I am Kimmy Hogan, today filling in for the fabulous Dana Brooks. Today, we are talking mental health with our wonderful guest, Dr. Heather Flynn. Heather is a clinical psychologist. She is a professor at FSU's College of Medicine, and she's the director of the FSU Center for Behavioral Health Integration. So, welcome, Heather. We are so happy to have you today.
Thank you, Kimmy. I'm really excited to be here. I love every chance to spread the word about my favorite topic, mental health. So thank you for having me.
Wonderful. Let me introduce our panelists, then we'll hop into it. Today we have with us Kia Thomas, who is the Public Relations Manager at Basic Brooks. How are you doing, Kia?
I'm well. How are you?
Doing great. I love that hat.
Thank you.
So cute. It's so cute.
Also today we have my law partner, Carrie Roan. Hey, Carrie.
Hey.
You're fresh out of some depositions.
I'm going to be quiet because we're right next door to each other.
I know I can hear you through the wall. And then, of course, we have Rose Caswick, our legal eagle and drink maker. How are you, Rose?
I'm good and happy to be here.
What drink did you make for us today?
So this is a Moscow Mule with some jalapeno infused vodka in it for a little extra kick. It's in honor of Nadia Tokolanikov. She's the sure. I don't speak Russian, but she's one of the founders of Pussy Riot, which was the big punk activist group in Russia that got thrown in jail a couple years ago, and there were all these big anti-Putin protests. So she's a awesome lady with a kick of her own.
Awesome. Well, cheers to her.
Cheers to her and her whole group. They're badasses.
That's awesome. Well, Heather, Dr. Flynn, let's go back to you. So tell us first what you do at the FSU Center for Behavioral Health Integration.
Sure, I'd be happy to. I'm wishing I had one of those Moscow mules right now. Yeah, I've been honored to start and direct this program since 2015. I started this with a man named Bob Sharp, who used to run our state Medicaid office, a wonderful man. And so the goal of our center really is to partner with people like you or any organization that would benefit from figuring out how to integrate mental health and substance use into their environment. So we work with mostly medical care settings, helping doctors learn how to detect and treat mental health conditions, as well as social service agencies, organizations, and branching now out into corporate and businesses because mental health in the workplace is becoming a huge topic. So we really are, like our name says, we like to integrate best practice information on behavioral health into other settings that don't traditionally deal with mental health because it's so pervasive.
I went on your website on the FSU Center for Behavioral Health Integration, that website, and I saw an image where it had 3 circles with mental health, substance abuse, and then primary care. And that was interesting to me because I've always thought of you go to your primary care doctor and they should be taking care of everything, right?
Exactly.
But I guess maybe not, that's not what we're actually seeing in practice.
That's exactly right. I'm glad you tuned into the 3 circles because that's really kind of the crux of what we're trying to emphasize. And you're totally right. And there are historical reasons for this, but the primary care setting should be a kind of a one-stop shopping for getting the ball rolling on a lot of your health needs. And mental health should not be distinguished at all from health. Mental health is health. And so our goal would be, and some primary care docs are clearly doing this, would be for mental health to be one of the vital signs. So you go in, you get your weight, you get your blood pressure, you get your temperature. These are all signals that tell the doctor, how's your overall health looking? So they can follow up on things like a high blood pressure or something. We would love to see screening for depression, anxiety, substance use included as the next vital sign for so many reasons, because you can't be healthy without mental health. And so this is something that, with some laws changing and policies and reimbursement codes, it's certainly something that's doable. So our center likes to go out and do training for doctors if they feel like uncomfortable or ill-equipped to do that.
Yeah, that makes sense. Let me kick it over to Carrie Roan and give her a chance to ask you some questions.
So I love that because I think that one of the issues with mental health is it's been a stigma for so long. Like people are embarrassed because they have a mental health diagnosis or they need medication to help, treat a diagnosis. And to me, if you make it part of just their regular checkup and their regular routine, like every other piece and part of their body, it takes away from that stigma. I mean, the brain is an organ just like your heart is. They check your heart, they check your lungs. I mean, why aren't you checking your brain on a regular basis every time they check your blood pressure? So I think that's a really good idea. And I think if kids have that part of their regular checkup, then they get used to being asked about their mental health. They get used to talking about their mental health. And that takes away the stigma from the kids too, especially boys, because you don't want boys thinking, oh, I'm weak because I feel anxious, or I'm weak because I feel depressed or sad. You want them to be able to talk about those things because, like I said, the brain is a physiological part of your body and it's not always healthy. So
you got it, Carrie. That's absolutely right. And we wouldn't feel the same level of embarrassment or stigma if we had low blood sugar or elevated, high blood pressure. And a kid wouldn't feel embarrassed if they, had a broken arm, something that we consider physical health. So, and depression and anxiety are exactly like those other conditions: diabetes, high blood pressure, asthma. Asthma is a good analogy in kids. It's something that can be dangerous and life-threatening, but needs to be detected and managed over the lifespan, just like depression and anxiety. And I'm really glad you brought up kids, because part of our work now is working with pediatricians, exactly what you're saying. And actually even further back than that with obstetricians. So even before the baby's born, we can get the ball rolling on taking a look at who's at risk and what can we do to prevent worsening of this over the lifespan. Just like if a kid had asthma, you wouldn't ignore it until it got super bad in adulthood. You want to manage it early. And so that medical analogy is right on.
Well, and so what would you tell people to look for in their kids? And so my kids are teenagers. So my worry is, I'm not trying to get like free counseling here, but my worry is always that there is depression going on or anxiety. And, teen suicide has become so prevalent and it's so freaking scary to me and everybody else, I think, that I always want to be looking for any type of sign of depression. But teenagers also fluctuate from one extreme to the other, especially, well, I only have boys. So to me, 1 minute they're mad, then sad, then crying, then happy, then exhausted. So what should parents look for in order to really figure out if it is depression or anxiety versus regular hormonal normal kid stuff?
Yeah, that is a great question. As you say, it's more confusing in kids and especially in teenagers whose moods do fluctuate. Their personality seems like it's changing a little bit too. So it is a challenge and it's difficult, but that's the exact right time to pick it up so that people can get on the right, pathway. So there are a few things that you would want to look for. One is a drastic change in their functioning, the way they think, the way they talk, the way they act from what you consider normal for them. And that would include things like not wanting to go to school or having a lot of anxiety about school, not wanting to hang out with their friends, which they usually want to do kind of no matter how they're feeling. And then, anything else that seems concerning, like hurting themselves, cutting behaviors. There's a whole array of things that parents and peers can look at and say that's not like that person. And the change, if it lasts for a while, in other words, it doesn't go away in a couple of days, goes on for a couple of weeks, that's something that you would absolutely want to reach out, starting with your pediatrician or your primary care doc, and let them get screened. We have valid, very accurate screening tools. And it's for that reason, it's so hard for even a doctor to look at a kid and say, this is depression. But we have tools just like that blood pressure check that we can, find out where they score and see if it really is. The other major factor that I want people to think about is family history, because if you start seeing some of these signs and symptoms and that mom or dad or grandparents had substance use, schizophrenia, depression, bipolar, that's somebody you want to pay a little bit closer attention to because it does tend to run in families.
Very interesting. I want to know what Key is thinking.
Well, all of this has been some great information because during the pandemic, especially with kids, it seems like they were experiencing so much. So Carrie, thank you for touching on that. One of the things that I wanted to know is what are some of the most common, mental disorders that you have been coming into contact with, since the pandemic, because it's become less taboo and we're now finally talking about it because it's way more prevalent. Right. So what are some of the ones that you've had to treat and, how do you approach these?
Yeah, that's so timely. I would say the 4 that we're seeing worsening or greater prevalence right now are depression, anxiety, substance use, and I just blanked on the 4th one. Oh, increases in suicidal behaviors, which is very concerning. So we have an outpatient clinic in town called FSU Behavioral Health at Appalachia Center, and we've seen, we opened just in the very beginning of the pandemic, and it's not what I was expecting, but we saw a huge influx in middle school age and high school age and even into college age kids with drastically significant anxiety, like we've never seen. And I'm hearing that from my colleagues around the United States. They're seeing huge increases in adolescent anxiety. And so some of the things that, the good news about that is it's highly treatable. We have therapies that can really teach a kid how to recognize and manage and cope with their anxiety. And some of the studies even show that can prevent them from getting worse over time and having another episode later. So what we want people to do is come in and get treatment because we know we can treat it. So that the increases in anxiety and actually even some increases in depression we've been seeing in kids, which sometimes manifests, as Carrie was saying, as more irritability or irritable mood, withdrawn, not necessarily tearfulness or sadness like you'd see in an adult. So yeah, we've definitely noticed it.
Gotcha.
So oh, sorry.
Go ahead, Kim. No, it's all you.
I was going to say, do you, the pandemic itself was stressful, but do you think that the increase in younger children having the anxiety was coming from the lack of social interaction or fear of the unknown of the disease, or did y'all kind of drill down on where it was coming from?
Yeah, I think it's all of the above. I'll say that as Heather Flynn and not based on data because we don't have the data yet. People are collecting information on that right now. But everything you mentioned from my, being a clinician most of my life, it's probably all the fear of the unknown, the uncertainty. One big thing for kids and adults is the schedule disruption. I mean, we all have been completely out of our routines, and routines are so important to maintain our brain functioning. Everything in your body runs on a circadian rhythm, a 24-hour clock, and our routines help keep that clock constant. Sleep, wake, the time you spend with friends, school, the time you eat your meals, that kind of stuff, the time you exercise. And it almost seems like during the pandemic, everything was a new decision every day. So all the rapidly changing adjustments that kids aren't necessarily well equipped to deal with all these adjustments. Adults aren't always, equipped for that. So the schedule disruption, the fear of the unknown. I think the isolation is very, very important. Humans do not do well when they're isolated. We're social beings. We need to be around people. And then social media, there is a lot of data on the effects of social media on kids' depression, anxiety. Seeing those images of other kids seemingly way better off than they are has a major effect on their self-esteem. So
does that impact adults too? Like,
yes,
we don't let our kids have social media because we've read some of the studies on how it impacts negatively kids because they're not emotionally prepared for the rejection, or they get that little dopamine hit every time there's a like. Does it have a similar negative impact on adults?
Well, you guys tell me. I think it does. I mean, although our brains are better developed and we can do some we can think in ways that they can't. We can say, well, social media is such a biased representation of a person's life. You know, we can tell ourselves that. We can override some of these immediate reactions in a way that kids, you know, and even teenagers, because their brain isn't formed till they're like 21. So we can do some of that stuff, but I see it taking a toll on adults as well.
I don't know. Chris, what are you thinking?
It's interesting on the social media front, because during the last year I've started like watching a lot of TikTok, and it is fascinating and it's addictive as heck.
It sure is.
From what I've seen on TikTok, it feels a lot more real than
Yeah.
stuff that you see on Instagram. Like it's less influencer, make everything perfect culture. It's like, I'm going to grab my phone and I'm going to film myself doing something silly, or my cat or my friends or whatever. And it seems a lot less serious. And I think that is almost like, it helps feel connected to people. And I think probably during the pandemic that, I don't know, it helped people overall versus they stayed up way too late and overloaded their brain on 90-second videos. But it was like, yes, everybody's going through this and kind of just trying to joke through it, sort of. It's interesting. Yeah. And then also going back to talking about the primary care, you know, we're personal injury attorneys. We read a fair number of medical records in our profession, and like you'll see that in the record sometimes, like there's a depression screen or a domestic violence screen, something like that. And I really like seeing those in there, but I do wonder how often they're really being done, and like, I'm going to go through these questions with you versus it auto-populates in the electronic medical system. Because I know, like, when I go to my primary care doctor to talk about mental health, it's very like self-diagnose. It's like, I'm depressed, I want to change my drugs. What am I gonna do? And you know, there's not like a questionnaire, there's not really a screening. It's just like, you know, I guess yourself for the most part how you're feeling, unless it's something, you know, more serious that you're not recognizing. Is there doctor, sort of a difference between how you treat or how you approach people who are having sort of like temporary bouts of depression or anxiety brought on by life events versus something that's more chronic or more serious, like a bipolar or schizophrenia, something like that?
Yeah, absolutely. First off, on the primary care question, you're totally right. It's not done systematically. It kind of depends on which doctor you go to, and are they using a validated tool? In other words, a tool that we know actually picks up on the illness. And unfortunately, like you're saying, a lot of the burden really is on the patient to be proactive, but it's weird because the symptoms of depression make you feel bad about yourself, withdrawn, hopeless. So a lot of folks with depression, because of the symptoms, they don't say anything.
Yeah.
So
my anxiety medication ran out and I'm too anxious to go to my doctor to get more.
Right. And that's part and parcel of having those issues. And so what we want to see again is the doctors to just universally screen everybody, and that way they don't miss anybody. But a lot of my research is actually looking at medical records for that very reason. Yeah. And I find that a minority of records actually have, you know, accurate information about mental health. So I don't, you know, if I want to know about mental health in their patients, I do a screening tool with the patients. I don't check the medical record. Now, some docs do a fantastic job in town on that. So it's certainly not everybody. And then the other thing that's confusing for everybody, for patients, for doctors, for most of society, is your last question. You know, what's different between some like temporary stress and having the illness of depression or anxiety or schizophrenia or bipolar? And that's really important, because that's one reason why people don't seek treatment, because they like normalize it and say, oh, it's just because, you know, I'm getting a divorce, or it's just because I'm going through this change or transition. And that may be true. So one of the big things that distinguishes more mild or passing symptoms from a diagnosis that needs medical treatment, one is the duration of symptoms. So if it goes on for weeks into months, that's not a normal, you know, reaction. And if it's severe, in other words, so what clinicians look for is is this significantly interfering with your ability to function at work, at school, with your family? Is it causing impairment? And is it lasting a long time? And how severe is it? But again, those things can easily be like checked off by a doctor. We have ways to diagnose, and they're very solid ways to diagnose. As I was saying to Kimmy earlier, one of the big things we look for is a family history. If it runs in your family, then you want to pay attention to that person. The treatments are different too. So if somebody has some mild distress or an adjustment to a divorce or losing somebody or grief or whatever, usually some counseling or support really does help with that, talking through it with somebody. If somebody has the illness, it usually requires either medication or really specific structured psychotherapy, or both medications and psychotherapy. Just like if you injured yourself, you would probably need like maybe a little surgical option, maybe some medications, but you definitely would need physical therapy too. The physical therapy works together, with the meds and other things. So for me, the treatments are a lot like, orthopedic injuries. If it doesn't go away, it needs treatment. And if it's severe, it needs treatment, and it's interfering with your functioning, it needs treatment. So again, I want to have a positive message, which is treatments work. They treat people to full remission. People can recover completely, as long as, just like asthma, they pay attention to the risk factors and get back in treatment when they need to. It can be managed very well over the lifespan.
So I have a question, Dr. Flynn. You mentioned earlier that if things run in families, and you also mentioned that addiction is a real hot topic right now. So it's no secret, but I have addiction in my family. And again, I have 2 teenage boys, and I sound like a worrywart.
Your mother, that's what you sound
like.
Yep.
But my question to you is, I am very open with my children about the addiction disease in my family and who it affects and how it affects them and how it impacts our entire family. And I want to know if there's some type of secret, or what is the best way to prevent the passage of the addiction gene or the addiction disease or whatever it is from one generation to the next.
Yeah, that's a good one. And that's one that we don't have like a magic bullet, like one answer to. But one of the things, addiction runs in my family as well, and 1 in 4. So it's very, very common. So you're not alone. One of the things that, when a kid is old enough to kind of understand, like when they get into their teenage years, I think, and that's the time when they're getting exposed to substances, like with their peers. That's, to me, the best time to, in whatever way you can communicate this with your child. Just explain to them, look, this runs in our family, and you may not be able to do all the same things the other kids do because of this issue. So whereas your friend might take a drink or some drug and be fine and not get addicted, you are at a higher risk, because once that drug hits somebody's brain, we know that if they have a real vulnerability, that might set up a risk for a problem. Mm-hmm. So one thing is just to explain to the kid, be very careful. You in particular need to be very careful because of our family history, just like, any other illness that runs in the family, a high cholesterol, hypertension. They got to be careful with their diet and that physical activity. So it's the education and trying to limit exposure. I know that's really difficult too, but we know that families that live around, this is kind of weird, but if you live around in an area that has more liquor stores, there's higher rates of alcohol use. If you're in a region where there's a lot of drug use, whether that be cocaine or methamphetamines or opioids or whatever, you're higher risk. So, limiting exposure is difficult, but it's pretty important as well.
Do you have any like treatment resources that you could refer to anybody who's watching for anybody who has a family member that they need to get into treatment for addiction?
Yes. Well, our community is very lucky in some ways. We have a really wonderful kind of one-stop resource, which is 211 Big Bend. Yeah. So if you call 211, first of all, they have 24-hour suicide crisis intervention, which is wonderful. Very well-trained folks answering those calls. we work together with 211 at FSU at our center to develop a comprehensive referral directory for our region, for Leon and the surrounding counties. And they also have what they call mental health navigators now at 211. So they will work with the caller to find the right referral for them based on like where they live and their insurance and their age and all that. And then they'll follow up with the caller to see, did that work out? Do you need other referrals? They'll make, I think, up to 3 or 4 follow-up calls. So that's really like one way to customize the referrals to whoever's calling, because it's so different depending on your insurance and things like that. And so for me, that's the easiest path for people to get a referral.
Thank you for that.
I want to give a shout out to our normal host, Dana Brooks, who's watching us from afar. So, hey, Dana, she's leaving us some love on Facebook. Heather, I wanted to circle back to something you'd mentioned earlier, which is mental health in the workplace. So tell me kind of what you mean about that and what it is that y'all are doing to get into workplaces to talk about mental health.
Yeah, no, that's a great question. There's some national data coming out that's really striking and interesting. One is that among people who are considering leaving their job, almost 60% cite as the reason mental health. I've never seen data like that before in my life. It means people are talking about it, recognizing it. Clearly, the pandemic has had an effect on that. And so corporations and organizations are really trying to bring in information on how they can create a culture of wellness in their business or their workplace. And it's just really interesting to me, being somewhat old. You know, I've never seen this kind of an emphasis on this. So CEOs are starting to think about instituting rules like no email after 5 p.m., no email on the weekends. If you're on a vacation, put your out of office. Setting up resources for people, for their employees, somebody to talk to, tools for maintaining wellness in the workplace. So whereas the first 25 years of my career, I never had a business reach out to me, I've just had like 7 in the past few weeks. So I think CEOs are starting to reach out to professionals to kind of help them create this culture of wellness, because they're seeing the effects on their employees, and not just absenteeism, but turnover and something we call presenteeism. So even at work, you're not your best, you're not functioning well. And it's, again, cited now as the major reason why people are considering leaving the workplace. So there's a big emphasis on it right now.
So I'm wondering how a workplace would go about talking to their employees about their mental health, because I know as an employee, I would always want to put my best foot forward, right? You don't want to admit that you're overwhelmed. You don't want to admit that you're not up to whatever task you think you need to be doing. So what kind of tools do y'all give to the workplaces for them to kind of be able to ask or support without making people feel bad about saying, hey, this is too much for me?
Yeah, and you just nailed the line that employers have to walk. I mean, that's exactly, where we need a lot of help and coaching, because you don't want to overstep and make people feel threatened or vulnerable or scared that they're going to lose their job or get demoted or anything like that. But you want to open up the conversation so you can help them. And the way that you talk to people about it really matters. So I'll get to that in a second. But the first thing is modeling. So if you have the bosses modeling healthy workplace behavior, that really speaks volumes. I mean, that's one of the main things that I think sets the tone for the workplace, is how the leaders are behaving. Are they working 12, 15, 20 hours a day? Do they expect you to? I mean, that's one thing. So we're starting with these organizations with the leadership, just focusing on their wellness and their, the extent to which they think it's important to embrace and model, for their employees. But speaking with an employee is more of a delicate matter. And so there's just a couple tips that I would throw out there. One is to start the conversation. It's got to come from a place of trust. That's paramount. That's like the base of the triangle. And so whatever you can do to help with that trust. So a lot of things we talk about in my field are confidentiality. So where will this information go? Are you going to share it with anybody else? Is this going to go in writing somewhere? Let's talk first about where this conversation stays and where it goes. That really helps with the trust. And then the second thing is your relationship with the person matters, and acknowledging that relationship. So I'll just make something up here. So, you know, Kimmy, I'm your boss. I know we have a relationship where I'm responsible for evaluating you and your paycheck and your job and everything like that. I'm taking off that hat right now, and I'm reaching out to you as a peer. I'm concerned, and I'm coming from a place of concern. So you want to explain why you're asking, and ask an open-ended question. If you feel comfortable, can you share how you've been doing? And then let the person, you know, say what they're going to say, and you can kind of go from there. But it's got to come from that relationship and that trust. And you got to be clear with people. We've heard examples of bosses and CEOs, you know, telling other people what happened in that conversation in the workplace, and that's just not okay.
Yeah.
Unless that's agreed upon in advance by the person. That does not help with trust. So so that's all really important too. And then building tools like proactive, rather than being reactive to mental health issues in the workplace, being proactive. So creating that culture of wellness, having tools, resources available like on the website or easily accessible by the employees. Where do I go to if I'm not feeling my best? You know, you can click on, and there's a lot of resources out there. You don't need to reinvent the wheel. You can just pull in and curate resources that already exist for people. And then have them reach out. You know, EAPs, employee assistance programs, are kind of mixed. I mean, some people feel comfortable with that, and some of them are good, and some of them, you know, are not. So we have to augment the EAPs, I think, with other resources.
What are the EAPs? What is that?
Oh, I'm sorry, employee assistance program. Yeah, so a lot of workplaces have that, and that's a place where employees who are struggling with mental health or whatever can go as a first line. They usually have free sessions or free visits.
Okay.
Yeah.
I have so many more questions for you, but I don't want to hog it all. Kia, do you have anything you want to ask Heather?
I think you were going into it, because definitely mental health, with Kimmy bringing this up about mental health in the workplace, it is even more prevalent now since the pandemic. And I know I keep going back to the pandemic, but we have never before talked about mental health like we do now. So one of my questions to you is, are you currently, and I know you talked about, you know, companies reaching out to you, are you going into them as a consultant to assist them with, like, in a sense, on the job training of how to actually, you know, handle mental health in their workplace? Because there are a lot of people working in workplaces that are very hostile currently, because things are so in demand. So I was just wondering, when you're going into these places, what exactly are the tools that you're providing them to be able to handle this training so that they know how to accurately or efficiently handle this?
Yeah, no, that you're absolutely right. I think a lot of well-intentioned bosses and coworkers make big missteps. The other thing is that I feel like everybody, this is just an anecdotal, you know, Heather, as a citizen observation, everybody's a little more irritable than usual, a little bit more short-tempered. So I'm trying to be much more patient and understanding than I ordinarily would be before the pandemic. That's just, you know, something I'm doing. As far as the going into the workplace, so first of all, I've been waiting since like 1991 for everybody to be talking about mental health. So I'm excited. I'm glad that finally everyone's talking about it. This is again what we've been working towards in my field. Let's get it out there. Just like if someone has a seizure at work, I mean, it wouldn't be, you'd know how to handle that, right? You'd get them hooked up to treatment, and you'd give them some accommodations. You'd make sure that they were, you know, safe and comfortable where they worked. So I'm glad that the conversation's going in this direction, but you're totally right. The first step we would do with an organization is awareness education, that, you know, like we're talking about now, what's the difference between mental health and mental illness? You know, what are supports that you provide for people who are having some transient distress or symptoms versus somebody who needs medical care, you know, so there are differences there. And then with then we're doing a lot of just coaching and role playing in terms of how do you talk to your employees? What are do's and don'ts? Because people don't know this stuff. I mean, they're not, how would you? It's not part of people's, it's my job, and it hasn't been part of most other people's jobs. So, I think the do's and don'ts, and I think really being very culturally aware of differences in people and how they might think about mental health, how their families and their neighborhoods might think about it. That is paramount. No one person is the same.
Right.
So we really want to customize, the way we address people and deal with people. Those are great questions.
Yeah.
Thank you.
All right, I'm jumping in. I want to put one of my questions in. It's a kind of a shift, but I know that y'all also talk a lot about postpartum depression. And I saw a statistic on the website that said only 15% of women with postpartum depression ever receive professional treatment. And so I wanted to shift over to that conversation and just ask you a little bit about your research in postpartum depression and why do you think such a low percentage of women get help with that?
Yeah, great question. It's all the reasons we've been talking about. They're obstetricians, not their fault, but they don't get a lot of training in their residency programs on how to address mental health. They know everything there is to know about getting that baby out safely. And that's their focus. So one thing is that their doctors, who they do trust quite a bit, whether it be their nurse practitioner, their midwife, or their obstetrician, there's a lot of trust there. And it's a missed opportunity, to detect what risk issues might be going on in the mental health realm. So, and then I alluded to this before, but a lot of the obstetricians don't use a screening tool, which that's our project now, is we're trying to implement screening in all the OB practices in town. So that will help the obstetricians figure out, okay, who's at risk, who's, having a bad day, who's, who needs help, who needs this kind of help, that kind of help. So a lot of these women get missed, unfortunately, during pregnancy. But it's such a prime opportunity because, as you know, if you've had a baby, you're going to the doctor a lot. I mean, in the end, you're going like every 2 weeks, sometimes, maybe even every week. So there are plenty of opportunities to pick it up. And so that's where we see our work fitting in really well.
That's crazy to me that there's so little detection, considering that is the time in your life probably that you're being observed from a medical perspective more than ever. You're seeing your doctor all the time.
Right. And you have a good relationship usually, and you trust that person. And so that's, I flip that coin around and say, what an awesome opportunity to detect, psychiatric and substance use issues. And it's the best time to get started on care, because once you deliver that baby, your schedule and your life is pretty occupied. So what we like to do is get people detected during pregnancy so that there are no surprises postpartum. I mean, we have the tools and knowledge to figure out which women are more likely to have a worse outcome postpartum in terms of mental health, and how to connect them with what they need before they deliver. That's our whole kind of goal here. But the short answer to your question, why so little, it's the stigma. I mean, it's really related to that. I mean, it's a time when a lot of women feel like, I should be the happiest that I've ever been. And so it's that discrepancy between what's wrong with me? I should be feeling happy and I'm not. Yeah. And then they got everyone else around telling them, oh, congratulations, this is great. You must be so happy. And that's really, really actually difficult for women who are struggling with depression and anxiety, because they're actually not happy and they feel guilty that they're not happy. So that compounds the depression even more. So again, if we can flip it and just use this medical model, like if you have gestational diabetes or preeclampsia, high blood pressure in pregnancy, that's a very important risk issue that needs to be addressed and treated. It's not like, get over it, you should be happy. No one would say that if it were diabetes, right? Or no one would say, come on, get that blood sugar up, just try harder. You would get treatment. So when you think about the medical analogy, it's kind of silly, right? So.
I remember when I was pregnant with my first son, I was fortunate to have a lot of women in my life that were talking about postpartum depression a lot. and just as like a normal thing, a natural thing. And so when I was getting ready to have my son, I remember thinking like, I'm going to be hyper vigilant, always asking myself, how am I doing? How am I doing? And it was because I'd been fortunate to have that kind of framework from my friends. It was like an anti-stigma, right? They kind of prepped me, like, hey, this could be something that happens. Like, let's just always be on the lookout for it. And so I was always on the lookout for it. I was fortunate I didn't end up having postpartum depression, but I thought it was really helpful that I had that frame of reference and that framework in my mind going into it. And it sounds like that's exactly what y'all are doing with the OBs, is getting people to.
That's exactly right. And we love it when people have a peer network that's helping them. The peer support can be remarkably helpful if you have the right message from the peers. So yeah, but we don't want it to be left to chance. You know, you were lucky and you had those friends around you, but we want everybody to have access to that same information. So that's a great example.
Yeah.
Agreed.
I have a question if nobody else does.
Go ahead.
Again, I don't want to like hog the airtime, but so so this is about medical marijuana. So this is a big shift in the conversation, right? Going from pregnant ladies to medical marijuana. But,
not necessarily. I'll explain that in a minute.
So we're personal injury clients, and we're personal injury attorneys, and we have a lot of clients who are in pain. And I have a lot of clients who have a lot of psychological diagnoses as well, and they've been prescribed medical marijuana. And I see a big difference. Like Kimmy or Rose was saying earlier, we review medical records pretty much all day long. And so I see a lot of clients and a lot of medical records where medical marijuana is extremely beneficial for psychological diagnoses like anxiety and depression, much more so than pharmaceutical drugs. So I'm just interested to know, I don't know anything about it. I don't know about its efficacy rate. I don't know anything about it. So I'm curious to know if you have any research on it, or you as a healthcare, as a mental health professional, what your perspective is on, how well medical marijuana is treating things like anxiety and depression and other mental health diagnoses.
It's a great question, and we just do not know. What we do know, and I actually have some data on this I'm trying to get published right now. What we do know is just what you're saying. A lot of people and a lot of pregnant and postpartum women are using it, and they're saying that I'm using it not because of a medical issue, but because of my anxiety, because of my, pain, of course, because of my depression, because of my PTSD. I started studying and interviewing pregnant women back in, whenever that was, 1997, 1998. And we had a lot of, many women report that they're using marijuana for nausea and vomiting, morning sickness. And at that time, and still through today, because of the federal status of marijuana as a controlled substance, Schedule I controlled substance, which is illegal, researchers have not been able to study it. So it's now, like this moment in time is the first that we're really able to take a careful look. So I can't say whether or not it's effective or safe because we don't have the studies. I'm very eager to see those studies come out. Doing a real study, like you randomly assign people to using marijuana or something else, and then a control group, and then you see how effective are they in treating the symptoms. If you're going on patient report, it's very effective, but we have to do the studies. So I look forward to the next 10 years so that we can. And then the thing that has always concerned me is we don't know about the effects of marijuana during pregnancy and breastfeeding. We just don't. There's no information or data. So that's something else for me that's a huge research need, is to figure that out. We have a lot of data on antidepressants in pregnancy, but we don't have any data on marijuana in pregnancy.
Yeah, I guess you probably don't have a lot of pregnant women lining up saying, "Hey, I'm smoking pot while I'm pregnant." Like, let me in the research study. People are probably a little bit hesitant to do that.
There are ways. I mean, when you interview women and you get their trust, and you have the confidentiality and everything, they'll tell you anything.
Yeah.
So Heather, what things are you particularly researching right now?
Well, we're very excited because we're doing kind of two parallel lines of projects, one in pediatrics and one in obstetrics. And what we're actually doing is we're helping the practices to implement routine screening for all these things, like we're saying. We're providing them training and technical assistance to feel so that they feel comfortable in managing these conditions in kids and in pregnant and postpartum women. And then the other part of our program is we're giving them access to a psychiatrist so that they can consult on the phone during business hours on diagnosis, what medication should I use, because both pediatricians and obstetricians aren't super comfortable sometimes with those decisions. So they can talk to an expert on the spot. And then we're providing statewide resources and referral for the OBs to help their patients. And so we're really looking at the impact of really equipping the doctors with all these tools on rates of detection of behavioral health issues, rates of treatment and treatment use. And then ideally, you know, from other states and from other projects, we know that once you put all that in place, patients do get better. What we'd love to see is the prevalence go down. So, you know, having these, you know, like you're saying, all this early detection in kids and pregnant women. I mean, that rate of 15% has been the same since the 80s. I mean, so we really need to make an impact on getting more women treated and better.
Mm-hmm.
So these are both programs we are partnering with the Florida Department of Health, so that we're hoping that we could then take what we learn and then implement it and sustain it statewide.
Oh, that's fantastic. That's really exciting.
We're really excited.
Yay. Well, I know we're coming close to the end of our show, so I wanted to give everybody a last opportunity to ask you some questions. I'm going to pitch it over to Rose.
Yeah, I've been thinking, I saw that aside from postpartum issues, you have a particular interest in working with women. Are there particular mental health, either illnesses or symptoms that you see arise more in women versus men?
Yeah, I mean, well, depression is twice as common in women as it is in men. And so that is one of the reasons why I got interested, because I'm a depressionologist. I'm a depression person. So that's one of the reasons I got more interested in studying women, and especially the pregnancy period, because that is such a high impact time, because depression affects the baby too. So it's like a 2-for-1. If you can help the woman, you can help the baby. So there are some, you know, so the risk periods for women are puberty, the perinatal period, and perimenopause, the time frame leading up to menopause, these hormonal transitions. So there are a lot of special issues in women, but for me, the main thing is the prevalence. You know, I like to have an impact, and it's you know, as many as 1 in 5 women will have depression in their lifetime, and that's a huge number of people. And especially if they're caring for babies and kids, they're the main caregiver. You know, it's really important to treat in women.
You're just trying to reach the most people.
Yeah, exactly. Right. I care about men too. You know, these women are having boys and girls, right? So we want to impact the prevalence in both boys and girls.
Like Dana always says, we love our men too.
Yeah. Yeah, we do. All right. What about you, Kia? Any final thoughts or questions?
Could you give us a little bit more information on the FloridaMomsMatter.org? Because we have been talking a lot about the maternal mental health, and of course, me having 3 kids, all ranging in different ages. I know I have gone through it myself, but if you could give us a little bit more information on that.
I'm really glad you brought that up. I forgot about that. So the Florida Moms Matter is the website for our Florida Maternal Mental Health Collaborative. So this isn't necessarily an FSU thing, but this is a statewide group of stakeholders. So people who have an interest in maternal mental health, all coming together, from government agencies to clinicians, survivors and advocates, women who've struggled with this in the past. So we have all different kinds of payers, you know, people coming together statewide as part of this Florida Maternal Mental Health Collaborative. And we put on a conference every year that gathers all the stakeholders together. We meet throughout the year. And what we're trying to do is look for the needs and the gaps in the state of Florida and see what we can do to rally and mobilize people to address those needs and gaps, whether that be research, advocacy and policy, awareness, education, or clinical care. So those are our 4 domains we work on. And I think the most important take home from the FL Moms Matter is that that's where we house our statewide resource directory. So we have a statewide maternal mental health resource directory that's searchable by insurance and location, like I was saying with the 211 thing. But this is statewide. So this is a go-to for women looking to get help in their communities anywhere in Florida. So the one thing that I do want to say about that is we're now working on identifying providers of color, so that people can feel comfortable finding a provider that they trust and would feel comfortable with. Because if you don't know this already, there are significant Black-white disparities in who gets the help that they need when it comes to mental health. And so our group is really focused on trying to disseminate information about disparities and ways to achieve health equity, and to make sure that we're incorporating that in everything that we do. So I'm excited that we are now working on, identifying providers of color for people throughout the state.
Awesome. And just to kind of, and this is on another note, what are some of the non-social cues that we can possibly be looking into with our kids and, friends and family, so that we can kind of pay attention to that? We hear it sometimes in their voices, but sometimes we miss it with like the social cues, I should say nonverbal cues, I'm sorry. So we miss those social cues. So what should we be looking at for?
Well, again, it's hard with teenagers, but excessive sleeping, that's one thing, or not sleeping at all, decreased need for sleep, significant changes in their eating and appetite all of a sudden. I mean, like significant, like they start to really gain or really lose weight, like more than 5-ish, 10 pounds. Withdrawal is a key factor, not wanting to interact or talk, like I said before, especially with their friends. So shutting down, closing down. There's a lot of self-harm behaviors that go along with this, cutting, other kinds of things. So I would say most of the cues are probably going to be nonverbal in kids. I have yet to meet a kid who will come up and say, I'm experiencing 5 of 9 of the symptoms in the DSM-5. So it's hard. It's really difficult. And again, if it represents a change, so if there's somebody who loves to go play sports or loves to, go out to the movies or whatever they do with their kids or with their friends, and then all of a sudden they don't want to do that at all, and they're real standoffish when you ask them about it, that's another cue, I would say.
Okay.
Is it the same for adults? Like you should look for the same kind of nonverbal cues from adults, like coworkers or family members?
It is, yeah. I mean, if they suddenly have no interest in things that they usually are interested in, that's one of the main symptoms of depression. Excessive irritability, that's another one. Some people think of depressed mood, but irritability is a symptom as well, especially in women, and well, actually in men too. So increased substance use, that's another sign to look for. It's something that has changed during the pandemic. There's now we're seeing reports of increased alcohol use and drug use during the pandemic, which I think is underlying depression, anxiety. So it's similar in adults. It's just kids are more difficult because they don't always have the language, to say what they feel.
Yeah. All right, well, Carrie's joined me in my room. You want your final thoughts?
Yeah. My battery died on my laptop in my other office. No, I just think this has been wonderful. I mean, I think I've pelted you with a million questions, and I'm sorry for that, but
no,
really great. And I hope as many people as possible watch this and learn something from it. If you have any other resources you want to share with us, now would be a good time. I know 211 Big Bend is huge, and Dana sat on the board of 211 Big Bend for a long time, so we're a big supporter of theirs. I know
the FL Moms Matter website is for maternal mental health. That's our resource directory. And I have a bunch of resources for, we have a national suicide prevention hotline that's also very good. So I'd be happy to send you guys if you want to put them on your website.
Definitely.
Thanks.
That'd be great. Well, thank you so much, Heather. We've really enjoyed having you on, and thanks for all the good work you're doing.
Thank you. You guys asked the best questions. I really, really appreciate the opportunity. Thank you guys so much.
Thank you, Heather. We appreciate it.
Thank you.
Bye.
Bye.